Welcome back to day 2 of AMCHP 2018. Hope you had an enjoyable time last night at the reception and the exhibition hall and got to see some of our wonderful poster presenters. This morning we move into a very exciting portion of our program. We're going to introduce our Emerging MCH Professional Award winners. These awards recognize outstanding and emerging state or local MCH professionals whose work has made substantial contributions to their state MCH program, their state's maternal and child health outcomes, or other significant contributions to promoting and protecting the health of women, children, and families in their states. This is the 5th year that AMCHP will give these awards, and every region in the country has the opportunity to recognize an outstanding MCH leader. Many of us understand the need for vibrant and talented young leadership to help write the next chapter of maternal and child health. We encourage all states to nominate their emerging leaders in the future. So at this time, it's my pleasure to present this year's award winners. We will start with Region 1, and the winner is Katie Stetler. The next award is for Region 4, and it goes to Dr. Morgan McDonald. The next award goes to Region 5, Candy Bush. For Region 7, Heather Smith. So clearly, I've not had enough caffeine yet. I jumped from Region 5 to Region 7. There's 6 in between there. Dr. Natalie Archer. Region 8, Audra Bishop. And Region 10, Dr. Allison Martin. Congratulations to all of our emerging MCH professionals on their many accomplishments. Now it's time to open the second day of our conference with a very important conversation and plenary. At the closing of yesterday's session, you had an opportunity to see a preview of this session seen through the eyes of Puerto Rican youth coping with the aftermath of Hurricane Maria on their island. Today's plenary, Caring for Families During Times of Severe Crisis, will allow us to delve more deeply into the importance of the role of MCH and Title V in caring for families and children before, during, and after crisis response efforts. Please welcome to the stage, as I introduce her, Dr. Michelle Davis as the moderator of today's session. Dr. Michelle Davis is currently serving as Health Commissioner of the U.S. Virgin Islands for 2 years under an agreement with the federal government. She has previously worked in the Virgin Islands in her federal capacity as Regional Health Administrator for Region 2 within the U.S. Department of Health and Human Services. She has worked as a public health professional in a variety of positions at the federal, state, and municipal levels. This included the Deputy Secretary for Health for the Pennsylvania Department of Health, Deputy Health Commissioner for Policy and Planning with the City of Philadelphia, and Senior Epidemiologist with the Centers for Disease Control and Prevention. She's also held positions with the states of South Carolina, Indiana, and New York, and at the local level with the City of Detroit and with the District of Columbia as a CDC federal assignee. Please join me in welcoming Dr. Davis.
Okay. All right, get ready. Okay. Great. So good morning, everyone. I'm so pleased to be here today at AMCHP's annual conference, participating in this very important session. I'm going to initially begin with some slides to tell you a little bit about the Virgin Islands. Okay. So this is the first slide, and I just wanted to make mention of the fact that the U.S. Virgin Islands is actually 4 islands: St. Thomas, St. Croix, St. John, and Water Island. Water Island isn't on this map because it's very, very tiny, so you can't see it, but it's south of St. Thomas. Next slide, please. So this is just a little bit of information about our governor. He took over in January of 2016. The Virgin Islands at that time had about 106,000 people, but due to the hurricanes, we have lost many people. They've come to the mainland and gone to other countries. One thing I'd like for you to note is that our total poverty rate is about 24%, but for children, it's about 32 to 33%. So we have many people that are in need. Next slide. So these are just some pictures before Irma. You can see at the top, beautiful, bright, sunny day. And then at the bottom, you can see, and this is September 5th, we have begun preparing for at that time, it still was a Category 4 hurricane. It turned into a Category 5 later that afternoon, covering up our windows, and then you can see the water rippling. Next slide, please. These are just some slides showing where the health department is located. So we have offices on 3 islands. On St. Croix, we had one large building that's totally uninhabitable now due to the breach of water and wind. On St. Thomas, our staff were located in several different buildings, but they've had to consolidate. And then on St. John, we have a public health clinic that we're actually sharing with the urgent care center that was on St. John that was totally destroyed. On the right-hand side, you can see we set up our EOC. We set up an area for special needs patients, as well as equipment coming from the DMATs to assist us. Next slide, please. So after Irma and Maria, you can see that there's a lot of devastation of homes, devastation of the airport, devastation of our ports, and our ports are just now getting cleared out. Next slide, please. So on this page, we've had a lot of, on this slide, we've had a lot of visitors come giving us donations. You can see up at the upper left-hand corner, our governor with Mayor Bloomberg and Tim Duncan. He's a Virgin Islander and a former NBA player. The lower left-hand side, one of our newspapers saying devastation. The upper right-hand side, MSNBC saying that the Virgin Islands experienced severe damage. There wasn't much media about the Virgin Islands initially. Mayor Bloomberg actually chartered a plane and brought the national media to the Virgin Islands so that we could get into the press. And unfortunately, at the bottom, I'm showing you, then there's Governor Cuomo in one of our shelters talking to children. We had many shelters opened up on all 3 islands, on 3 of the islands. And then at the bottom is actually a public housing authority located on St. Thomas, and it suffered the most severe damage of any housing project in the territory. There were approximately 400 individuals that lived in that housing authority, and the housing authority was totally demolished, and you can actually see straight through the front of the building to the back of the building because the winds just blew the walls straight through. And we actually lost an individual who was blown out as a result of the hurricane. And then the last slide, you can see where a lot of their possessions were. Next slide, please. So here, I'd like to begin thanking AMCHP once again for letting me be here. But I have to say thank you to my staff that are in the audience, and I can't see you because these lights are very bright. But Dr. Derval Peterson, who oversees maternal and child health, and two of her staff, Charmaine Myers and Kathleen Greenaway. Without them and other staff, we would not have been able to care for our mothers and families. And so some of these pictures depict some of the things that we were doing. As I've just stated, Hurricanes Irma and Maria posed a variety of challenges for our territory's infrastructure. We had displaced families, still have damaged facilities, no power, limited potable water, drastically reduced healthcare services. Both of our hospitals were severely damaged, and we're working at about 50% of capacity. Both of the health departments on the islands were severely damaged, as well as the urgent care center. We're in the process of actually planning to bring in 5 temporary modular units, 2 for the health department, 2 for the hospital, and 1 for the urgent care center. Despite these obstacles, the Maternal and Child Health with Special Health Care Needs program remained resolute. Their leadership of the nurses and the staff who worked in our shelters, provided clinical services, assisted with the Emergency Operations Center, and multiple outreach events for the communities. As the reality of the response of the hurricane became our new norm, we were resilient and adaptable in meeting the needs of our community and piecing together various program activities. The newborn hearing screening program remained vigilant in testing newborns in each district and identifying those that were displaced or may have been relocated. The nurse liaisons worked closely with each hospital to ensure that newborn genetic testing, notification, and counseling continued, and that any missed babies were identified and followed up. Our case managers continued to reach out and locate clients to coordinate care for children with special health care needs, reconnecting them to services as needed. And all of this was being done in personal cars, in our parking lots, on our mobile van, because we don't have our work homes, and many staff lost their personal homes as well. We're still providing care through our mobile health van and just began resuming actively recruiting for families for the home visiting programs, which has been a godsend. Our Nurse Family Partnership on St. Thomas and our Healthy Families Virgin Islands on St. Croix. And we're working with a team of EMTs who came to us from Arkansas on St. Croix. And we've actually started up the community paramedicine program. And so our EMTs are going out and visiting individuals that had to go to the emergency room that they picked up. And they're working with all of the programs, including maternal and child health, in our agency to do this, to keep people out of the emergency room, as well as to keep them out of the hospital. Despite the lack of landlines, no cell phone services, and passable roads, the nurses went out to reconnect with their families. Program enrollment has now surpassed pre-hurricane enrollment as they welcomed other families that are at risk, struggling, or in even greater need for services. Though through generator power, clinical services resumed as soon as the all clear was given. And during the response efforts, maternal and child health served as the point of contact across the territory for the distribution of FEMA's infant and toddler kits, adult mosquito nets, and baby nets, and we distributed approximately 2,000 infant and toddler kits territory-wide. Next slide, please. This is another slide that talks about our Zika Action Day, so we're continuing our services. Next slide, please. Here's our baby shower on the dock, and this was a partnership with Princess Cruise Lines. This occurred about 3 weeks ago, and Baby Zone, and they donated many newborn supplies. We also worked with a volunteer organization named Fathom, and they travel around, and wherever they travel, they like to do good work. And so they brought donations as well and worked with us on the dock to distribute all the donations to the mothers and families. We we served an estimated 500 families in need that day. As the recovery efforts move forward, maternal and child health continues to embody and exemplify the passion and grit of public health. And for 2018, they're going to be working on many things, such as strengthening our Title V block grant performance measures, collaborating on the survey to identify needs in meeting our state action plan, partnering with our epidemiology team to initiate a pediatric health brigade that's going to occur in March, and assisting with strategic planning of resuming much needed dental services in the Department of Health. They'll also be working with the University of Vermont Leader Education and Neurodevelopment Disabilities Fellowship Program, and building family support and engagement activities and community partnerships. So as stewards of maternal and child health, the maternal and child health team has demonstrated a tireless commitment towards ensuring the health and wellness of women, children, and families, and children with special health care needs in the territory despite adverse conditions. And we look forward to continuing this work in 2018. Just in closing, just some other pictures of activities that we've done. Okay, so as the moderator today, allow me to introduce our session and panel. Today, oh, thank you. Thank you. Thank you. Thank you. Thank you. Okay. As the moderator today, allow me to introduce our session and panel. Today we're going to learn quite a bit about how MCH is important to emergency response efforts, including interagency collaborations between state and local jurisdictions. We'll also hear from local experts who will share how they are addressing their local response, including provider outreach, what they are seeing and hearing from patients, referral systems of care, incident management teams, and how we can use what we are learning today for the future. Today, we have with us Dr. Miguel Valencia Prado, Children and Youth with Special Healthcare Needs Director for Puerto Rico Department of Health. Yes. We also have Dr. Umar Shah, Executive Director of the Harris County Public Health Department in Houston, Texas. We also have Ms. Leslie Kowalewski, Chief of the Maternal and Child and Adolescent Health Division for the California Department of Public Health. We have Cassandra G. Paisley, Director of the Division of Children's Medical Services for Florida Department of Health, and Christina Mullins, Director of the Office of Maternal and Child and Family Health for the West Virginia Department of Health and Human Services. So I'd like to thank all of them today to be here with us. And more information about the panelists' bios can be found on the conference app. Now let's get started with Dr. Valencia.
Good morning. So really, I am going to talk about Zika epidemic and hurricanes in the middle. I'm going to talk about Zika in the middle of hurricanes, but in a kind of ways, Zika was a hurricane. It was like a silent epidemic. We know it was coming, but we had no way of tracking it, so we need to get prepared for it. Okay, this is a short chronology of the Zika epidemic. We documented the first case in December 2015. Everybody was looking when the first baby was going to be born with birth defects. So in May, we identified the first fetus with brain abnormalities, intracranial calcification, all the characteristics of a baby that was exposed to congenital Zika. This is a very sad story because this mom went twice to get tested, and the people in the emergency room just say that she had an allergic reaction to a fish she ate. So really, we made the diagnosis after the baby was identified. Then in October, we had the first live birth with a congenital Zika syndrome. Another sad story because it was an immigrant that didn't have opportunity to get insurance. So she got her first ultrasound late in the pregnancy, so we knew that the baby was Zika positive because we did the test after the baby was born. So by June, we already have 40,374 cases in the population, and of those, there were 3,762 pregnant women with laboratory evidence of Zika infection. That number, as of December, went up for another 400 pregnant women. So in June, the Zika epidemic was declared over. It was kind of a problem because physicians, communities thought that Zika is over, and it's not. So this is how we are organized. This is a new division that was created in October 2013 to respond to the autism community and provide services, but it is the perfect setting for responding to Zika and was the perfect responding for the hurricane. So you see the only thing in pink there is the Zika active pregnancy surveillance system. It's different from the state registry because it is an active system that was built upon our birth defect that is also an active system. We operate through 7 regional pediatric centers and 2 autism centers that are, the priority in those autism centers is diagnosis of children less than age 3. But for the 2 emergencies, they were also to provide support to all families. So the first thing was I received a call from the state epidemiologist and say, hey, Miguel, are we following microcephaly? No, why? Zika is coming. Okay. Let's do the work. Let's get ready for it. So the first thing was, what is the definition of microcephaly? There's no universal definition of microcephaly. So we have to establish the definition. Then we need to go back. Okay, how we are going to say that we have more cases of microcephaly if we don't know how many cases we had before. So we have to establish the prevalence for 2013, 2014, and 2015. And then we included microcephaly as a reportable condition beginning on January 2016. So we, in coordination with CDC, we decided to develop SAPs for tracking all pregnant women with a positive test. And we knew that we have to do outreach to educate the people about testing guidelines. And especially we were concerned when we did the prevalence study that we were looking at health conference like 12, 13, 14, but 12 and a half, but they were missing the 12 and 1/8. And when you're dealing with microcephaly, a 0.1 millimeter is significant. It's the difference with making a diagnosis of microcephaly or not. So, yeah, we need to do training on that. And also, we say, well, we would like to identify, because the problem was that it was silenced. I don't know anybody with Zika. You have only 1 of 5 who had symptoms, so nobody was worried about Zika. So the problem was cocooning this pregnant woman and making sure they were tested and that we were able to identify these infants as soon as possible, preferably during the prenatal period. So that was the reason we hired this person using 35. It would be a liaison between all the MFNs. We have 5 on our program just to make sure that we have the information as soon as possible. So during the epidemic, July, September 2016, we went to all 37 birthing hospitals. We worked with the nurses there. We brought measuring tapes that were scaled in centimeters that were donated by the CDC Foundation, and we also got infantometers just to make sure that the measurements and the health conference measurements were accurate. So because we have a direct line responding to the Secretary of Health, everything we did was backed with an administrative order from the Secretary of Health that make it law in a kind of ways you have to follow. So we had the first one, so all facilities now would need to change to measurement in centimeters and kilograms. And then we work with the demographic registry to make sure, because health conference was not among the information that you have to take report. So now it's law, since October 1st, you have to also include microcephaly in the information. In August, we started working with the maternal fetal medicines. These are them. These are extraordinary people. They took time off their busiest offices to meet every Monday in the afternoon. So we agree with them that because there was some problem with press reporting everybody, when is the first baby going to be born? So not all babies that we can identify and are born with microcephaly necessarily was related to Zika, because now we knew that there were babies being born with microcephaly before Zika. So they agreed, by law, they have to submit any information. If they identify a pregnant woman with a fetus that has birth defects, they have 2 weeks. But for Zika, they agreed to submit in 24 hours. Even more, there is one that called me from the examining room. Hey, Miguel, I'm seeing this patient, and I'm seeing this. So there was a very close collaboration. And with them, we were able to develop the guidelines for the evaluation and management of the pregnant woman. So again, this became an administrative order. So now they are required to submit by 24 hours. And also the guidelines were included in the administrative order also, so they have to follow that. We did the same thing for the pediatric follow-up. So we developed the guidelines, the TATU5 program, developed the guidelines for the follow-up. We used CDC guidelines, but we went more than what CDC guidelines were recommending. So we circulated them among all the pediatric associations, got their feedback, and then that went also into the administrative order. So they have to follow that also. So we want to have a uniform system. This is what it looks like. If you see, one of the differences that CDC initially the recommendation was to follow and do the eye exam only if the baby was Zika positive. We decided we are going to do the eye exam in every kid born. So now the recommendation, 1 year later from CDC, is we need an eye exam for every kid, either if positive or not. So that time we were ahead of time. So most of the funds for the epidemic initially were for surveillance and education, prevention. No money for direct services. So it was not until July that CDC released this opportunity, so we were able to hire at least 7 regional service coordinators. Then the Zika AMCHP services program came, and we got $60 million. Okay, that's good. So now we were able to increase our workforce, start working equipment, because remember, by this time, the predictions from CDC was that we were going to have around 100 to 270 kids with microcephaly related to Zika. So we want to be prepared to receive those babies and to provide the services. So we have money for equipment, we are implementing the telehealth technology, and we also want to provide services. And after that, it came CMS Zika, so we got more money, 22 million. So we are working with that money at this point, and this is how the system looks like. So we have 3 ways of identifying babies. So SAPs, we can follow the pregnant woman until she's her due date, and we can follow with the baby she delivered. We use the MFNs to try to identify those pregnancy outcomes when the families decided to terminate or interrupt the pregnancy. And then we have the Zika birth defects, and the birth defects that allow us to identify children that meet the definition, but by some reason the mom was not tested. She came to Puerto Rico from another place, and we can pick them up right there. To the far to the left is the children with special healthcare needs. So we are doing mostly, we want every family, every kid, every infant that is born from a mom that was positive to come to us to provide service coordination and developmental surveillance to cover that gap, because we know that developmental surveillance is currently not available, if we can say so. Kind here is that we partner with APNI because I'm on the money. We also have, we recruited service coordinator, but we also recruited a family support and engagement staff. And we are working with APNI, who is the largest parent, and is the parent association, and it's also the parent information training, so we can have that with us. So right now, we are serving close to 60% of all children that have been born, but look that there are about 286, that number is over 300, that have moved to the States. Where? Everywhere, okay? So we are tracking those. I have 20, so we are working with all the states to get the information where these families should go when they move to the state, but also for them to know our information. I have 1 minute to cover Maria. So, priorities. No, they told me I can go 2 more. Okay. Sorry. I would do it short. Okay, so priorities were the infants with inborn errors, mothers with infants born to sick, the technology dependent, and children with autism. So we made sure that these families had the adequate supplies before the storm and after the storm, and they have access to the supplements to our pediatric centers. Zika, we were tracking them. Problem was landlines, nobody have that anymore. Phone signal were line, and prepaid phones, they change the numbers every week. So we sent our teams, service coordinators to the community to try to locate them. So that was a good strategy. We located most of them, and they went with the tools to do the developmental screening. So if they cannot come to the center, we will go to them. So we did that. This was new for us. We thought that it was covered, and they told, oh, we only have 30 kids, technology dependent, okay? So we started getting calls, and these families, we identified 118 families with kids depending on technology, and all there were the challenges that were presenting after the storm. So they need clearance to come to the States. There were airline requirements, portable equipment. So one family said, I have the money, I have everything. I just need some help to somebody to help me locate some distributor that had the equipment so I can pay for it. So we did that. So this team, we put together a pediatrician nurse family representative. This was a wonderful team. So they developed a survey. We called every family. Then we sent people from the pediatric center to visit the family and make sure what they need. So we ended up with, almost through. Not me, I'm trying to. Next slide. Okay, no, next one. Not working. Can I have the next one? Slide. Need some help. Not working. There we go. No, too far. One back. Well, that was our working word. We said there, family needs, suppliers, providers, airline requirements. So that was our working words to help these families. And finally, for autism, we opened out all our centers for support. We made reach to the Alianza Autismo, the largest association serving this. So we are okay, yeah. Okay, but we knew that there were children that just having no power, no water, changing their routine, they should need some help. So we offered them our services at the centers. With that, I'm done. Thank you. So we have this was fast. We have a poster presentation. Please come and see us, and we can talk more. Thank you.
So thank you, Dr. Valencia. Our next speaker will be Cassandra Pesley.
If you were here last year, you know that I am incapable of managing a slideshow successfully, but I'll give it my best shot. So a quick snapshot of Florida's population. We have approximately 21 million residents in the state. 4 million of whom are children. And by the national definition of children with special health care needs, we have approximately 600,000 children, but our state statute has a different definition of that term. On average, we have 112 million tourists in Florida every year. And of those, 44 million, separate number, 44 million individuals tend to travel through the Miami International Airport annually. We are a peninsula surrounded by water on 3 sides, and each year we go through the Atlantic hurricane season, June 1 through November 30. And also our neighbors, the islands near us, are also in that same hurricane season. So we are prepared for routinely having hurricane impact, but nothing like what we had this year was anticipated as a part of the preparation. So I'll discuss 2 quick topics. I'm going to try and make up a little time. Dr. Miguel and I made a pact that I would try and offset as much time as he went over. But I'm not sure I can hold up my end completely. So our services are primarily locally provided. We have 67 county health departments, and the county health departments are a part of the State Department of Health. February 2016, our governor issued an executive order directing our state surgeon general to declare a public health emergency due to Zika. We had travel-related cases in 4 of our counties. So since that time, women have been allowed to receive free Zika testing regardless of whether they have had a risk until December 2017. Now, we're a Medicaid managed care state. The managed care plans cover Zika testing, private insurance covers Zika testing. However, for anyone who is uninsured, our health department continues to provide Zika testing for a pregnant woman who meets the CDC criteria. So that's the difference. Now, we're no longer testing what we refer to as the word well. We're continuing to educate about the transmission, not just mosquitoes, sexual transmission due to our population traveling around the world and entering our state quite a bit. So if there's transmission happening anywhere, we believe our message needs to remain strong. We talk about prevention quite a bit, even educating our children, creating little booklets to make sure they understand that standing water should not be left around. Our first focus, we created a maternal and child health work group, and we are part of the incident command structure, incident management team. I'm lead. Members of my team are here. They're not my team in their day jobs, but they're my team as a part of the MCH response. And we had members of the team from Miami-Dade Health Department. She is not here, but Dr. Lillian Rivera was absolutely amazing in the Zika response, not just for Florida, but for everybody else who needed any information regarding some of the strategies that they put into place in Miami-Dade. So another focus, Dr. Celeste Phillip, who's our state health officer, later in the response made a request that not just we create systems for linking pregnant women to prenatal care, that we needed to actually create documentation so we would know exactly who has and has not been linked to prenatal care. And a part of that resulted in numbers like this. 82% of our pregnant women who were Zika positive were linked to prenatal care. The 36 women were actually tested and found out that they were positive at the time of delivery. So we've documented and have a process in place to reach any pregnant woman who tests Zika positive. And of course, you still get to decline services, but we definitely offer those services to those families. And it's not just prenatal care. We ask them whether they have health care coverage and help them to navigate through the Medicaid system and identify services in the interim until they receive Medicaid coverage. We had 9 babies born in Florida with laboratory evidence of Zika virus infection, 7 of whom were symptomatic, 2 are asymptomatic. Early Steps is our IDEA Part C program for early intervention for birth to 3. That program was already working together on eligibility, because in 2016, our legislature modified our eligibility criteria and added at risk in an effort to make children who have neonatal abstinence syndrome eligible for early steps in an at-risk category. That group was already together and immediately analyzed how do we determine who is eligible for early steps as it relates to Zika. So any child, any infant who is prenatally infected, who has laboratory evidence of Zika virus infection, is eligible, or born with any of the conditions known to be associated with the syndrome. Of our 9 babies, of course, 7 were symptomatic and 2 were born, and to my knowledge, do not currently have any evidence of a birth defect. We were one of the 4 states that received the Zika Healthcare Services Program grant. Dr. Miguel received $60 million. We received $2.3 million. We have, on average, we have 225,000 live births each year, 30 to 40,000 in Miami-Dade. But what we needed from, everything I say here is mine, not HHS or its agencies. So what we needed was not necessarily healthcare coverage. We needed infrastructure with expertise and access to mental health counseling and expanded hours for insertion of LARCs. So our first strategy was to designate 2 centers to serve as resource and referral centers, University of Miami and USF Tampa. Miami was the immediate first answer, but we worked our way to Tampa. So those 2 are the resource and referral centers. The Miami-Dade, University of Miami, and Jackson Memorial, there's a partnership and a collaboration there, and many of our physicians who are connected with those 2 organizations are actually becoming national leaders on Zika. And they have been an endless source or resource for us throughout the state, and we definitely appreciate particularly Dr. Ivan Gonzalez and Dr. Chris Curry. They were amazing. So then we go on to contract with for the mental health counseling with our Healthy Start coalitions, our Healthy Start groups in Miami, Broward, and Orange. We have not received the request for services that we anticipated. As with all of our strategies, we'll revisit them and decide whether this was the best way to do it, but we definitely want mental health services to be available to all pregnant women who are Zika positive and the families caring for the babies, whether or not the babies have symptoms. In the Miami-Dade Health Department, we added additional hours, ARNP hours, for the insertion of LARCs. My time is flying. So hurricane preparedness, we are the agency that is at the state level responsible for helping with the function of creating special needs shelters. We actually do these things. We make sure that the shelter is appropriate to receive individuals with special health care needs, children, and adults. And our local health departments are the point people who are handling this, but we, as an integrated agency, make sure that there are services statewide. These were the things we learned from Irma. We had 53 of our 67 counties with special needs shelters. Numbers were extremely large. What we learned is, because of Hurricane Harvey, there were resources already committed to Texas, so that seemed to have been a weakness, but the strength was, because of Hurricane Harvey, the public responded. So when the governor or any state officials said, you need to be aware, you need to evacuate, we had large numbers of individuals evacuating, but because we had 53 of our 67 counties impacted, the counties that tended to be the backup for the other counties were themselves impacted and unable to do that. We're in the northern part of the state, the main state office in Tallahassee. We were closed as well because our schools, our hospitals, all of our locations were serving as backup locations for the individuals who had to evacuate from the southern part of the state. Our managed care plan has a great system of preparing for storms. Every May, we prepare for hurricanes, and then if there is one, we have an impending storm preparation, and during the storm, the nurses man the special needs shelters, and the partnership with Hurricane Maria Paz, I'm sorry, I can't really explain, but it was a wonderful experience to have CDC, HRSA, Puerto Rico, and Florida on the phone, immediately seeing what we can do to assist with Puerto Rico. We have more room to grow, but we are definitely committed to assisting the families that are coming into Florida from Puerto Rico, particularly children with special health care needs. Thank you so much.
Thank you, Cassandra. So next we will have Dr. Umar Shah.
Hello? Can you hear me? Hello? Okay, all right, just making sure.
Good to hear you.
Dr. Davis, thank you for having me. It's been great to be a colleague of yours for years, and I want to really recognize Dr. Warren and also Lori Freeman. Really,
It went off. It went off.
Did I get
Yeah.
You
keep going.
Talk towards your mic.
talk towards my mic? On my,
It's working. Sounds better now.
hello? All right, where is that guy in the back with this mic? Hello? Can you hear me? Okay. I'm not touching it. I'm just going to speak. All right. So I just want to thank Lori Freeman and the AMCHP board for having me here today. I really just want to say it's just a great partnership. I do not have any of my staff here today, but that is going to change. After being here and seeing what the sessions are this year, I'm incredibly miffed that I have not sent my staff members here, and so we are going to be a part of this, I assure you that. So I just wanted to make that quick plug as well. I am joined by somebody from NACHO, actually maybe a couple staff members from NACHO here, so do want to just recognize that. So in the interest of time, and I've had Puerto Rico and sort of Florida here, and I'm in the middle, and they're talking about $50 million and $2 million, or $60 million and $2 million, and they're having these conversations. I feel like I'm the guy in the middle, so I'm going to do my best to keep going here, and I'm going to do my best also to try to stay on time, but I'm not going to be successful. I'll just let you know in advance. Now, the one quick thing I would say is that I had a conversation prior to getting up here with my colleague from California, and I'd say that we were talking about the fact that all of us have a story to tell about an emergency, a disaster, something that's going on that has been incredibly difficult for our community. But I hope what you do not take away from these shared collection of stories are the disasters themselves. I hope what you take away is the response, the hope, and the resilience of both the responders and the communities, that despite the incredible calamities, we are really moving forward and doing that successfully. So I'm going to just provide some perspectives about our department, Harris County Public Health, as well as, before I do that, I just do need to say a little bit about NACHO and our Texas affiliate, TACHO, and just say that I'm the current president of NACHO, and it's the National Association of County and City Health Officials, which represents nearly 3,000 local health departments across the country. And I'd say that the key word for this collection is the fact that it is a collective. It's the power of people coming together and health departments coming together. And I was the previous president of our Texas affiliate, which was 44 local health departments. And I just want to say that it's really important for all of us to come together. And that's what NACHO really provides, as well as AMCHP and other groups like this. So Harris County is a large community. We are 4.7 million people. We're the third largest county in the U.S. We're spread over the size of Rhode Island. We're home to the fourth largest city, New York, LA, Chicago, Houston. In about 5 to 7 years, we should be surpassing Chicago. Harris County Public Health is the county health department. We have a $100 million budget with 700 public health professionals who take a one health focus. We integrate environmental health as well as mosquitoes and entomology, animal health and human health, all under one umbrella. And just so you can see, that's where we're located, in the middle of the swamp of the Gulf Coast of Texas. Public health, we believe, truly is where people live, learn, work, worship, and play. And we do take a social determinants lens, which also blends into health equity. And we believe that health equity is really the most important E, the fifth E. But we believe that the 4 E's of economics, education, environment, and engagement are absolutely critical to the health and well-being of a community. So you can't see this very well, but just to let you know that Harris County is on the left there, and everything is in red. So all the factors that we look at when we relate maternal-child health or ill health in Texas or in specifically Harris County are frankly higher or worse than what's happening across the country. So we have a lot of work to do in our community, and it's a really big challenge when then you get hit by a large hurricane. And so Harris County, Houston, was the largest singular community that was impacted by any of the hurricanes of 2017. But it makes sense because we're the third, there's only New York, LA, and Chicago, and none of them got hit by a hurricane. So I guess that's the only way we could be the top there. That's not a distinction you want. But the hurricane did not hit us directly. It actually hit Corpus Christi, south of us. And if you remember, there was a high-pressure system. The hurricane hit, went north, and then stalled, and then started coming up to Houston, and it took about 4 days of rain, and it made landfall on August 25th, and we received rain for about 4 or 5 days straight. In our community, this was our third 100-year plus. My mic again. Hello. Third 100-plus year flood in 3 years. We've had a 100-year flood, a 500-year flood, and this is an 800 to 1,000-year flood. And if this were a rain event, this was a 2,000 to 5,000-year rain event. 30% of our county, again, the size of Rhode Island, water. 100,000 homes damaged, and amazingly, only 36 fatalities in our community. So what happens when you take a beautiful community and you add 1 trillion gallons of water? You get this. And that truck is actually on a freeway, and that's about 15 to 18 feet of water where that truck is. It's actually floating near the interstate right near our downtown. Obviously, WIC, women, infants, and children, have an incredible place in our community, and what you see in green are where our WIC sites are throughout our community. We have about 1 million children in Harris County. It's a large number of people, and as you can see in the shaded areas there, in the dark red there, that includes an incredible amount of poverty, children living in poverty. So we have a lot of health equity issues that are really contributing to the challenges in our community. Well, it didn't help that Hurricane Harvey disrupted our WIC services. And the Bear Creek WIC, which is one of our 12 WIC sites, actually was underwater. And so we had a drop off in the number of clients we were able to serve. Thank you. Maggie? Hello? Oh, this is so much better. Oh, I feel, okay, now I can walk. I'm just kidding. I had to do that, Maggie, sorry. Bear Creek has really went under water, and so the big challenge that we had was that when we got back, an incredible amount of our infrastructure was actually impacted by Hurricane Harvey. And so Gwen Sims on the left there, as well as Jolene Norbel-Harrell, are two of our WIC leaders, and they were themselves trying to clean up and figure out what we needed to do. But the community, this is an incredible story of community bi-directional relationship. The community helped respond for us. So that's a church where we set up shop, and also an H-E-B and a Kroger where we were able to set up shop and be able to provide WIC services in those shop, or at least get people to be able to get their vouchers and benefits cards, etc. But at the same time, our job as a health department was, remember I said that health happens where you live, learn, work, worship, and play? Well, Harvey hit us where we live, learn, work, worship, and play. And we responded where we live, learn, work, worship, and play. And so this is an example of what we did by setting up health villages throughout the community. We actually had 31 health villages with use of about a $2 million sort of assets that we had put together that we did not expect we were going to use for hurricane response. But guess what? Instead of doing a nice ribbon cutting ceremony September 25th, we wound up pulling them out, and we did health villages, 31 events in about 6 weeks across the system, where we set up, and our tagline was, when the community was not mobile, we needed to be mobile for the community, taking public health to the public. And these are some examples of what we were doing with WIC as part of medical, dental, mobile mosquito museum, et cetera, that we were providing throughout our community. So our response was a One Health response, as I mentioned earlier, everything from the healthcare system coordination and community engagement, shelter medical operations, disease surveillance, mosquito control. Obviously, we're also a Zika-impacted community in Texas. Environmental health, animal management, and mobile service delivery. At the end of the day, we really believe strongly that our community could not get to us or the health system, and we needed to provide those support services for it. So where are we now? There are an incredible amount of interest in what's going on. We've had greater than 22,000 homeless students, 13% report worse health. Of these, 60% struggled to obtain or afford care. 50% of affected residents have no savings. 33% of affected residents report worse mental health. And so the Kaiser Family Foundation, as well as Episcopal Health Foundation, put this early assessment together a month ago. And here's a quote from, I'd like to read to you. Yes, we're still catching up. We're still catching up with our bills. We're not at where we were at before. And now you're having to limit a lot. My son wanted a pizza. They're charging me like $5 for a pizza. I pay $1 for it at the store. I was trying to save a few bucks that I do have, but for my son, of course, I'm going to do it for him. I spent that $5 even though we were not going to have enough to eat again for the next couple of days. So what's needed is really a solution-based approach of really flexibility from states and feds, the federal government to really, and we're happy that we finally have a funding bill that went through. Not sure what that really means because it's been spread over 4 states and the territories, et cetera. Disaster planning and training must continue to happen, and we certainly need increased resource support. Community resilience is the name of the game, emergency preparedness, and making sure the health and well-being of a community comes together. And so this is my last slide, but I'm going to actually show a quick video. The role, because I'm at 15 seconds over only, so I'm not bad. The role of local public health just makes common sense. And that picture is me when I had hair and it wasn't gray in 2005. On the bottom right, thank you so much for the laughter. I appreciate it. Hurricane Katrina response at the Astrodome. 12 years later, we were doing the same thing at Hurricane Harvey and taking public health to the public. So let me show this video because I think this really highlights what we did. There's no better way than to just see it. Thank you.
So thank
All
you.
right.
Thank you, Dr. Shaw. Our next speaker will be Leslie Kowalewski.
Good morning, everyone. Oh, good, this mic does work. So I am going to be talking about the great state of California and the flames and the wildfires that engulfed our state. We learned a lot this past year, and we learned a lot about what the needs of moms, babies, children, and children with special health care needs are during disaster. So I'm here to share our experience and our next steps forward so that we can meet the needs of our population that we serve during the next fires. So 2017 was a record year for California wildfires. The state experienced 9,200 wildfires. 5 of those wildfires were the most devastating in recorded California history. On October 8th, everyone went to bed thinking that and knowing that we were going to have high winds in the northern part of our state. But what we didn't understand, because we've heard about high wind warnings throughout California over the years, what we didn't understand was that those high winds were going to knock over power lines, and it was going to ignite over 14 wildfires in the middle of the night, which evacuated 3,000 people by 4 a.m. in the morning. I don't know about you, but I can't imagine being woken up in the middle of the night saying that you've got to get out. You see red flames and you've got to run. What do you grab? Where do you go? What do you do? And as a state health department, what do you do when you're waking up and hearing about the devastation on the radio? By the end of October, over 250 wildfires had scorched Northern California, burning 245,000 acres, killing 43 individuals, burning down 8,900 structures, and 3 counties declared states of emergency. So we thought, oh my God, we're through October, we're done. And lo and behold, in December, we had fires break out in Santa Barbara and Ventura County in the southern part of our state. Over 50,000 people were evacuated, over 282,000 acres were burned, and over 1,000 structures were destroyed. And then the rains came, and I'm sure all of you saw the mudslides that occurred because of the fires. Those mudslides evacuated folks again and left 17 people dead. So what have we learned through this devastation in this past year of wildfires? We've learned that we need to do a better job communicating. We've heard from our local MCH directors on the ground that we've got a really wonderful state emergency preparedness office that talks to the local emergency preparedness groups, but they are often left out of the loop, like our state MCH department. We're not at the table. We're not bringing our population onto the radar of the folks that are entrenched in emergency preparedness. We need to do a better job. That is not universal. We find that our smaller counties are actually all hands on deck and have a much closer view of what is needed and are actually on the ground helping out in the shelters. We have some large counties that their role is to simply report out on their staff, and it's frustrating for them when they have fires burning in their county. They know that shelters are open. They have trained public health nurses on their staff, yet they're only being asked, so how is your staff doing? What services are you able to not carry out today? So we've got some tidying up to do in our state to ensure that our populations are being cared for during these times of disaster. One disadvantage we have with the California wildfires is they happened overnight. A lot of times it caught people off guard. And what we heard from the MCH directors is that chaos rules, that there was no order at times at some of the shelters. There were often times where they couldn't understand who was in charge. Was it the Red Cross that was in charge, or was it the public health department in charge? They needed trained public health nurses to go in and do those medical assessments at the shelter, yet sometimes it was up to the role of Red Cross to do those assessments. So who's in charge? So we need to take a look at the memorandums of understanding between the Red Cross and our health departments to really understand how best to meet the needs of the folks coming into the shelters. We also understood from the MCH directors that there was confusing terminology being used between voluntary and warnings of evacuation. What does that really mean? What does it mean at 3 a.m. when I've got to figure out, is this voluntary, warning, or mandatory? Who do I grab, what do I grab, and where do I go? Because of the fires, there were, and I think it has happened to all of us during the disasters, is that the cell phones went down. We didn't have internet service, and so families were left without a lot of information, which contributed to the chaos. What MCH learned during the fires is that calling the MCH directors and entities for information about the fire is a waste of our time. They actually are reporting to us that, it would be really great if you could call us and let us know what is going on with the fires, because we are in a situation where we're in a silo. We need information coming to us so that we can understand the scope of the problem. We also had on ready information about what to take to a shelter, what families need to know during the time of a disaster, but that's too late. So how do we get ahead of the curve and really start providing more information to families? So being personally prepared is another piece that we heard loud and clear from the MCH directors, and I've heard it mentioned from the stage, is that people couldn't get back to the office for lists, for information that they needed to staff the shelters and meet the needs of the populations they were serving. Suddenly, they needed good old-fashioned handwritten lists. They needed to be able to find a phone number on a piece of paper instead of in their phone, so that they could ensure that they were in touch with the staff and in touch with the folks in order to help really be at the shelters and help support in time of disaster. We also heard the need for personal backup. A lot of times, in most instances, as in all the disasters, schools are closed, daycare centers are closed, and if you are a parent, or you've got animals, or you're doing elder care, you need to be personally prepared for friends and family to step in and help you, because the systems that you may normally be using are closed. So how do you personally back yourself up, both in your car with a to-go bag and then with your social support system, so that you can go and report and help the populations you're serving? So what are we going to do going forward? We've already started to talk with our state emergency preparedness office to raise awareness about the needs of pregnant, parenting, and youth and children with special health care needs and infants. What we have heard is that there's needs that kids have that aren't being represented. For instance, we had adult particulate breathing masks distributed throughout the shelters, but there was nothing for kids or infants. So they were trying to take an adult mask and fit it to a child, and that's not what was needed. We need to have the right equipment and the right materials to serve all populations heading to the shelters. We also heard the need to train public health nurses, so we have more nurses trained throughout our state to handle in case of emergency. We're also looking at how we can use our PRAMs, our MIHA questionnaire, in the coming year to really understand how did parents prepare for disaster? Are they ready? What do pregnant women have on hand? Do they have their medical records? Do they understand the quality of care that they've had, so they could communicate that in case they go off to the shelter? We are also looking at how do we bring our state emergency preparedness office back down to our local MCH directors. How do we connect that? And so we've planned to do a call with all of our MCH directors to really let them understand firsthand what is the state doing from the top around emergency preparedness, and then encourage them how to get involved at the local level. There's a system, we just need to plug people into it in order to be ready for the next fire season. We hope it won't be another 9,000 wildfires. We hope that it'll be a better year next year. So with that, I'm going to turn it over to my friend and colleague that is going to talk about the opioid crisis.
So thank you, Leslie. And now we'll have our last speaker, Christina Mullins.
Thank you. I am from West Virginia, and as many of you know, we have been ground zero of the opioid epidemic for a while. we had genuinely hoped that when CDC released the most recent data, that at least some states would be, we would be leveling off, or at least not be so far ahead of the rest of you, but that didn't happen. We took another leap forward, and we are now at a point where we're experiencing 52 deaths per 100,000. So we lead the nation in overdose deaths, not by a little, but by a lot. So opioids have presented a significant problem in West Virginia for several years. In 2008, our physicians started calling our office saying that something was changing in our MCH population. They were noticing that our NICUs were full, and we were so naive then. We had no idea that there was a train coming right at us, and there is no end in sight to this. Now, as I mentioned, we have the highest overdose rate in the nation, and in 2017, 14% of all the infants born in West Virginia were born with intrauterine substance exposure, and 5% had a diagnosis of NAS. One rural county in West Virginia, the rates for NAS are at almost 11%. So substance abuse impacts the everyday life of nearly everyone in our state. It is not uncommon to see discarded needles outside of our building, which is in a lovely business section of Charleston, West Virginia. One evening, I even found a discarded needle in my own driveway rolled up in a rug. In addition, nearly everyone has a friend or a family member with a substance use problem, and most people know of at least one person who has overdosed or overdosed and died. This epidemic is shaking the foundation of our communities, and the impact to our MCH system is no exception. Our NICUs operate at capacity. Foster care is up by 63%, and the number of children requiring early intervention or birth to 3 services has risen 36%, which translates to an increased cost of $4 million per year every year. So $4 million this year, $4 million, more dollars the next year, more dollars the year after that, in our small state of 1.8 million people. My request for budget increases during our state's recession has been less than popular. So MCH has experienced several challenges standing up a response. We have learned that we are really, really good at counting deaths. We can tell you what they died of, we can give you all the substances in the system, but we did not have a way to measure intrauterine substance exposure, NAS, treatment availability for pregnant women, or the impact to our other MCH programs. We were screening for substance abuse at the prenatal visit using our maternal risk screening instrument, but we knew the problem was much greater than what was reported. In addition, traditional treatment programs were not prepared to treat pregnant women. While the situation will dramatically improve during the next year, we currently only have one treatment facility that will accept pregnant women for inpatient treatment. This facility has only 18 beds, an infant resident count as a resident, leaving room for only 9 mother-baby pairs. Because MCH frequently works across multiple systems and houses West Virginia's injury program, we have been thrown into the very heart of the public health response, taking on roles that are both traditional and non-traditional to MCH. I would like to tell you that we built programs because of data, but we didn't. In the beginning, we built programs because you could not escape the overwhelming need for services everywhere you went. As a result, the first thing we did in 2011 was build an outpatient treatment program for pregnant women based on the available best practices. It is called the Drug-Free Moms and Babies Program, and the evaluation data shows that most women participating in the program are no longer using illegal substances at the time of their delivery. At the time of our first evaluation report, we had served nearly 500 women, and around 70 to 90% of those women delivered with no illegal substances at the time of their delivery. That's way better than 18 beds. Then we realized that we needed a surveillance system for intrauterine substance exposure in NAS, but we couldn't agree on a definition. So we brought our neonatologists and our coders together for a day-long meeting, and we hammered it out. We defined NAS for West Virginia. Then we trained every single birthing facility on the definition. In 2016, we finally launched our surveillance efforts with an existing system. And you saw in my first slide where our rates are much higher than what are reported in national data systems. Within our Drug-Free Moms and Babies project, 85% of those pregnancies were unplanned, compared to about 50% in our overall population. Reproductive health services are desperately needed for this population. Now we are working to offer comprehensive, and let me emphasize the word comprehensive, reproductive health services to harm reduction clinics, prisons, and regional jails, emphasizing Title X guidelines, no coercion. As part of our commitment to the Title X guidelines, these agencies will be monitored closely to prevent coercive activities. In conjunction with our Child Protective Services Agency, we are also working to train our home visitation workforce to support families where a parent may suffer from a substance use disorder. I would be remiss if I did not also tell you about some of our more non-traditional activities. For example, Title V staff facilitated distribution of more than $1 million of naloxone kits to community-based agencies across West Virginia. The funds for naloxone were provided to public health by our Bureau for Behavioral Health. In addition, Title V staff are responsible for the oversight of prescription drug overdose surveillance. We have co-located Board of Pharmacy staff within our office to supervise and mentor the development of epidemiological capacity for that agency. These efforts resulted in MCH authoring, with some help from CDC, the 2016 overdose fatality analysis with the goal of identifying intervention opportunities in the year prior to an overdose death. Our state health officer requested a kind of social autopsy and assigned the responsibility to his MCH agency. Oh, the lessons we have learned. First, you don't always need a new data system to tell your story. We use many existing measures like foster care and early intervention to demonstrate the impact to children and families. We also lean heavily on our perinatal collaborative. Our physicians, nurses, and hospitals can move a ball much faster down the field than we ever could. Take some time to learn the language of your new partners and share yours with them. We now routinely work with narcotics officers, EMS, and correction staff. They do not always speak Larks, McVie, or statistical probability. Perhaps the most important lesson is that our workforce is exhausted and stressed. We have missed some time with our families, cried, laughed, gotten mad, got over it, and continue to grow through this process. I've had to advocate for vacations and breaks, sometimes forgoing my own to assure theirs. Now and then, they really can't do one more thing, and this applies to our EMS and our first responders. Our MCH office began feeling the true weight of this crisis about 3 years ago. I would like to share a few more things that I wish I fully understood then. Don't lose sight of your mission. We did not get here overnight, and we will not be finished in 1 year. We will still be required to report on those performance measures at our block grant reviews in August. Find ways to tie the work you do during the crisis back to those issues that support your mission. As MCH agencies, we excel at developing partnerships and seeing across systems. When something like this happens, seize your opportunities. We are rapidly expanding the skills and data capacity of our workforce in ways we never expected, and no one can take that from us. We are also developing partnerships with a host of new agencies and disciplines that now understand how MCH can be a critical partner in this crisis and beyond. Thank you.
So thank you very much, Christina. So unfortunately, there's not enough time for us to have a long session.
5 minutes.
We could, so we'll have a couple of questions, but you can only go like 30 seconds. Okay? 30 seconds. Okay, so I cannot see where people are, but is there someone over here at the microphone? Over here somewhere? I don't know. No one in line yet? Okay, so I'll let you think for a couple of seconds and I will say something. So we've heard many stories today about all of our experiences and lessons learned, and I really want to thank the panel for all of the useful information that they've shared. And we look forward to continuing sharing them. In the Virgin Islands, we're going to have a very long rebuilding period, as our other states are going to have as well. We're going to have to rebuild our public health, our behavioral health, our health care, and our human services system. The two Cat 5 hurricanes that we experienced over 2 weeks were extremely devastating, and we've had to evacuate upwards of 800 to 900 individuals, and it's going to take a while for them to come back to the Virgin Islands. So I briefly just want to thank a number of the states that have helped us: Tennessee, Arkansas, Washington, New York City, New Jersey, and North Carolina are actually sending us portable units, portable operating rooms and emergency rooms and dialysis units. Most of our evacuees are in the Atlanta, Georgia area, and we have evacuees for dialysis in Puerto Rico, Florida, Louisiana, Mississippi, and South Carolina. And we're very grateful to Congress with the disaster supplemental, and I know all of us up here are, but one thing about the Virgin Islands that's included in the disaster supplemental is now that we will get 100% of federal government Medicaid match versus our 45% to 55%. So that's really going to help us to maximize the funding that we have and continue to provide better services to our mothers and our families. So anyone get in line yet for questions? Okay, over here, go ahead.
Thank you all for the wonderful work you're doing. Quick question, do you have any advice for states in preparing for disasters or other emergencies for your undocumented or underdocumented populations, and especially considering they might not be any systems of to find them, and then also afterward, might not have the capacity to rebuild as many other families would?
Want to take that? Undocumented? Well, go ahead.
Me. So I think in Florida, if you can hear me, our focus really has been when you're asked for services, our focus has been on the delivery of those services. So we really haven't spent a whole lot of time asking you, how did you get to Florida? A large percentage of our Zika-positive pregnant women are from other countries. So our focus really has been, we're MCH, and we do MCH stuff, and we try to stay in our lane. That's our response.
Same thing for the Virgin Islands. Of those 800 medical evacuees, a lot of them were undocumented individuals from other islands in the Caribbean that experienced the hurricanes as well.
Yeah, thank you. I would just add, so in our community, I think it's really important that you build the trust in advance of the disaster, and I think that goes not just our community, everywhere. The name of the game is to make sure that folks trust you, and there is a lot of importance to building that resilience and that the reach out and the engagement in advance of the disaster, so that when you are at the disaster, at the emergency, that you actually can move forward with ensuring that communities are willing to come forward and be a part of the response. When folks were coming for Hurricane Harvey to our shelters. We had mass sheltering at both GRB Convention Center downtown, 10,000 people, and NRG, which is the Astrodome complex, for another 10,000 people. We did not ask for their documentation, citizenship status, etc. What was really intriguing was that we did have ICE and Border Patrol that were being used from the federal response, when they were deploying DMAT, and et cetera, and they were brought in to provide, because they obviously have security as well, security detail. They were brought in to provide security detail, but it was very clear by our elected officials that they were to stay in a certain area and provide a certain kind of activity, because we wanted to make sure that undocumented or those who did not have appropriate status were not in any way feeling like they could not get services or help from the response partners or responders. So I think it's really important to just say that up front. You have to build the trust in advance of the disaster, and then certainly leverage that when you're in the midst of the emergency.
Okay, thank you, Dr. Shaw. I have 10:02, and so I just want to thank our panelists again for their great presentations. And all of our jurisdictions really appreciate all the support we're receiving from AMCHP. Thank you.
Hello. I'd like to also thank our panelists and Dr. Davis so much. Many of our panelists responded to my personal plea to come here today and to speak, and I deeply appreciate all of them. I want to take a few moments just to personally invite you all to join us this evening for our Capitol Hill reception. We will have bus service to the Rayburn Building beginning at 5:30 p.m. this afternoon, and it will be out front of the hotel on the street. And I hope you'll be able to come and join us as we celebrate our legislative champions on the Hill. There will also be return bus service after the reception at 7:30. So for now, please enjoy the coffee break in the exhibit hall and have a great day.